And we are live. So good evening, everybody. I know it tends to go live before it actually starts giving me the feedback that I know that it's actually live. So I do want to say good evening to everyone that may be watching this and those of us that are here in the Zoom room watching this. And I welcome you all this evening to our week number 5. Our week number 5 of the DC Child Justice Coalition. We're a cohort of 10 caregivers, family caregivers, self-advocates, and advocating on behalf of our children who are school-age children. And so it's been a very exciting ride, and we've been flooded with a lot of useful information, and we're excited about this. I'm particularly excited, and I hope everyone else is as well, to learn more about Medicaid, which is so important for our children with special healthcare needs and disabilities, as majority of us have children with varying conditions, and ourselves having varying conditions as well. So this evening, we're joined by 2 incredibly capable people of helping us understand a very complex system, which is the Medicaid system, the DC Medicaid system. So we're first joined by Melisa Byrd, who is with the DC Department of Healthcare Finance, and Mark LeVota, who is the executive director of the DC Behavioral Health Association. So we're going to start first with Ms. Byrd, who's going to break down all things wonderful that DHCF does for our families.
Thank you, Shioma, and thanks so much for giving me the opportunity to join you this evening. I'm going to start sharing my screen, and hopefully this will go smoothly. And I will look as though I know how to use technology 2 years into the pandemic. And then this in presentation mode, hopefully. Okay, can everyone see my screen? For the folks that I can see, okay, great. So again, my name is Melisa Byrd. I am joined today with by my colleague, Carlita Belton, who is one of our managed care experts. So between the two of us, we hopefully can field any and all of your questions this evening. And at any time we cannot, we will follow up and reconnect with you after tonight's presentation. Quickly, I wanted to say the reason why I'm here is that the Department of Healthcare Finance, where I work, is the district agency that administers public health insurance programs for the district, and that includes the Medicaid program. Our vision at DHCF is that all residents in the District of Columbia have the supports and services they need to be actively engaged in their health and to thrive. Our work right now is focused under 4 strategic priorities. One is building a health system that provides whole person care. When we talk about whole person care, we are talking about the head to toe, everything in between, and from birth to end of life and everything in between there as well. We are looking to ensure value and accountability in the programs that we administer. And we're looking to strengthen our internal operational infrastructure. So that's making sure that we have what we need internally that's working properly so that our program operates in the best way. And then now that we have been in the pandemic for the past couple of years, Medicaid's made a lot of changes to hopefully make Medicaid more accessible and more easily accessible, and making sure folks keep their health insurance coverage during this important time. But we're going to have to unwind when the federal public health emergency declaration ends, and that's going to be quite an undertaking for the department. So that's now under our strategic priorities. So I'll do my best to talk about Medicaid in 15 minutes. We're going to talk really high level, and then whether it's today or at another time you have other questions about the program, please don't hesitate to reach out. Medicaid is a health insurance program, as you know, and it's overseen by the federal government, and it's operated by states. And in this world, DC is considered a state. Medicaid nationally provides health coverage to over 84 million Americans. It was established in 1965, and the federal government, in this case, establishes the basic rules, provides oversight, and helps pay the cost for the program. And when I talk about setting the basic rules, I mean the federal government has all states have to make sure they're covering certain individuals or populations at certain eligibility levels. There are certain benefits that are mandatory, and so on. As a state, we have the flexibility to set our eligibility level, so who can be eligible for the program, so long as they meet the federal floor. We get to establish the coverage, the benefits that folks can access, and then we get to set how much we pay and how we pay for those services. In the district, most low-income, non-elderly adults, that's a lot of Medicaid language for us, are Medicaid eligible. So low income is referred to as 200% of the federal poverty level, or FPL, or about $27,000 for an individual, or about $55,000 for a family of four, and that's an annual amount. I'll bring your attention to, if you can see the chart, the graph in front of you, where the district really is a national leader for coverage, is on the overall, just the levels of Medicaid coverage that are available to district residents, but particularly for childless adults and children and pregnant women. We have some of the highest eligibility levels across the nation. The DC Medicaid program provides access to a comprehensive benefit package or healthcare services. So as I mentioned before, we have to, as a state Medicaid program, we have to cover certain mandatory services that the federal government requires us to do so, but then we also can cover some optional services. And in the district, of course, we cover all the mandatory services, and we do cover a lot of optional services. Overall, this includes physician visits, healthcare for women who are pregnant. I highlight, you'll see the couple services highlighted in bold: dental, vision, and transportation to and from medical appointments are included in Medicaid coverage. And then I also wanted to highlight something that's really unique about the Medicaid program, and that's EPSDT, the early and periodic screening, diagnostic, and treatment services. And this is essentially the benefit that covers children, and that says that if something, we want to see early and periodic screening, and then if a diagnosis, if that's what is appropriate, and then treatment. And generally speaking, for children in the Medicaid program, if something is medically necessary, then Medicaid should be covering that service. So Medicaid services are provided, at least in the district, are provided either through what we call fee-for-service or managed care organizations. The difference between there are a few differences between the two. For fee-for-service Medicaid, you may also hear it referred to as traditional Medicaid. We DHCF contract directly with physicians, hospitals, dentists, all the healthcare providers. When they get paid for a service, they are submitting something called a claim to us, and we pay them for that service. The providers have no risk. If you provide the service, you get paid for it. You do have access to any Medicaid enrolled provider if you're in fee-for-service Medicaid. And then one of the for care coordination and case management, there are some areas within fee-for-service where that's available, but it's not a standard across the fee-for-service program. On the managed care side of the world, when we contract with the managed care entity, we are contracting with the MCO, which is the acronym for Managed Care Organization, and not directly with the hospital or the provider. And so when we make a payment, in this case with the Managed Care Organization, we pay the Managed Care Organization, and it will be the MCO that pays the doctor or the hospital, et cetera. In this case, it's the MCO that's responsible for the provision and coverage of health services, and they have to ensure that there's an adequate network of providers that can meet needs of the folks that they cover. And then the difference between managed care and fee-for-service, at least for us in the district, is that in managed care, care coordination and case management is part of the managed care benefit. Most residents that participate in the DC Medicaid program do receive their services through a managed care organization. We have 3 of our programs administered by DHCF that are delivered by the same 3 managed care organizations. You may have heard of DC Healthy Families, which is our Medicaid program. And as I mentioned before, Medicaid provides free health insurance if you meet certain income and citizenship and eligibility requirements. We have another program called the Alliance Program, which is a locally funded program designed to provide medical assistance to district residents who are not eligible for Medicaid. And then we have the Immigrant Children's Program. These 3 programs are administered through managed care organizations, and those 3 current MCOs are Care First Community Health Plan of DC, MedStar Family Choice, and AmeriHealthcare District of Columbia. We have a couple other programs that also are under managed care, but under different MCOs. So the Child and Adolescent Social Security insurance program known as CASIP, and the managed care organization that administers the CASIP program is Health Services for Children with Special Needs. We often refer to it as HSCSN. And the CASIP program is a program that provides children and young folks up to age 26 with special healthcare needs and receive supplemental security insurance, SSI benefits, or are SSI eligible. The second program, District Dual Choice Program, was just recently expanded effective beginning of February. And this, the District Dual Choice Program is a program that integrates Medicare and Medicaid benefits into one program. So there are a number of folks in the district who are eligible and enrolled in both Medicare and Medicaid. Medicare is a federally run health insurance program. And with dual choice, what we're trying to do is, instead as a person receiving both benefits of having to call two different entities, you now get to go to one health plan, and all of your Medicaid and Medicare services are provided through that health plan. And our current dual choice plan is United Healthcare. So there are many reasons why a state Medicaid program may choose managed care, including you do, as a Medicaid program, receive increased flexibility utilizing managed care organizations. MCOs have the accountability for enrollees' outcomes. So there's kind of one entity that we can hold accountable. You can increase the capacity to measure health and quality of life. We can make sure through an MCO that the delivery of the right care at the right time and in the right place. The example here is, you can call it, all of our MCOs have a nurse advice line that you can call if you're a beneficiary for some guidance on what's the best care approach, and versus immediately going to an emergency room. Although, of course, going to the emergency room, if that makes the most sense. It does, managed care does have the potential to improve lower overall costs, and it does provide a little bit more budget predictability for states. There are also a couple other things called in lieu of services and value added services. In this case, managed care plans, even though it's all Medicaid, but managed care plans are allowed to do some things that fee-for-service Medicaid is just not permitted to do. One of those things is something called in lieu of services. And so when there are medically appropriate, cost-effective alternative to a service that's included in our state Medicaid plan, which describes the services we cover, the managed care organization can cover that cost. And it's a voluntary alternative offered to the enrollee. So an example here is a home modification that allows a member rehabilitating from an injury to safely return home rather than extending a stay in a rehab facility. The other flexibility that managed care organizations can take advantage of is something called value-added services. And it's a service that an MCO may choose to provide at no cost to the district. And it's usually something to improve quality of care, reduce costs, but it's not something that's included in the amount that we pay that MCO. An example here is on a food prescription program, possibly Produce RX, for beneficiaries with chronic conditions where they may receive a prescription from their physician for groceries at a grocery store. So as the state Medicaid agency, DHCF, we set the requirements and expectations for the managed care organizations, and we oversee the MCOs. One expectation is that MCOs contract with certain providers. They have to have what we call an adequate network that ensures that folks can access the services they need. But just I think about 2 years ago, we started requiring something we called universal contracting. So now all of the managed care organizations that participate in DC Medicaid must have all the DC hospitals and all the federally qualified health centers included in their provider network. So that means it should not matter, or it does not matter, if I'm in AmeriHealth or MedStar, Family Choice, or Care First. If I need to go to George Washington Hospital or Washington Hospital Center, that hospital is going to be in that network. That's not the way it used to be. Prior to a couple of years ago, one plan might have GW Hospital and Washington Hospital Center in it, while another plan may have Howard and Georgetown, and then another plan may have Sibley and United Medical Center. So if you wanted a particular hospital and it wasn't in your provider network of your plan, you either didn't get to access that hospital, or you might decide to switch plans. And this way, we consider these critical providers, and so they're consistent across the entire Medicaid program now. The other, well, there are several expectations that we have on our managed care organizations, but the other piece that I wanted to highlight was about quality care, and that, you know, we monitor our managed care organizations to see what kind of care they're providing and if it's meeting our expectations. There's a number of ways we do this through routine reporting and consumer surveys. We also do things through a pay for performance program where we are expecting a certain outcome from the managed care organization. So we've been monitoring our managed care organizations over the past several years so that we reduce preventable hospital admissions, and so that we also reduce low trips to the emergency department that don't need an emergency department level of care. So going in for a sore throat when that could be handled otherwise. And so we are working with our plans and making sure that folks are going to the right place at the right time for the right care that they need. And with that, I know that Mark's going to talk a little bit more about quality. If you do want to learn more about the Department of Healthcare Finance and Medicaid, I've listed our website here. We have a new online portal and mobile app for folks to apply for Medicaid and other and staff and TANF benefits. And so that's called District Direct. Encourage you to check that out. It's also, for the first time, you can really manage your benefits. So you can go see when you need to renew or recertify, which isn't an issue during the public health emergency, but different things like that versus waiting for the paper to show up in the mail. And then finally, my email address and phone number are at the bottom of the slide. And again, as we go through, if you have a question tomorrow, once you think about things, or next week or anytime, or a problem with your own benefits, don't hesitate to reach out.
Great, thank you so much. And please, we'll take all the questions after, right? So Mark, the floor is yours. Thank you.
Great. Well, thanks, Shioma, and thanks to everyone for taking the time to learn more about the Medicaid program today. And hopefully you can see my screen now. So I want to talk to you in a little more depth about where your opportunities are to be advocates in the process of thinking about managed care. And so we'll talk today about understanding decision-making in managed care, talk about self-advocacy options, what some of the resources are for beneficiaries in managed care, and briefly touch on government policy making and managed care. I like to put all of my takeaways up front. So if you don't make it through the rest of the presentation, at least you'll hear some things that I think are important. One, the decision-making is a structured process in managed care to make sure that beneficiaries get neither more nor less than the care that they need. And MCOs, providers, and beneficiaries all have their role to play. Beneficiaries do have rights when they don't agree with initial decisions. There are people whose job it is to resolve beneficiary conflicts, and it's important to understand their goals, which may not match your goals, but they can still be helpful. And so we'll talk a little bit about their roles. And then, as important as self-advocacy is, the system will not change without system-level advocacy. So we'll talk about some specific options for you at the systems level. So decision-making, these three groups all interact with each other, and every group interacts with every other group. For managed care organizations, their key roles in decision-making are doing this thing called utilization management and utilization review, which is deciding whether or not care is going to be provided. And then they do population health management. So they think about the entire group of people that they have enrolled in their plan and try to think about ways that they can help to make conditions better for groups of people that may be struggling with similar chronic diseases, or that may be at risk of certain kinds of health conditions unless they get additional help and treatment. And so that's the high level. Those two things that managed care organizations do are thinking about on an individual level, is this care appropriate for the person who is asking for care and who's seeking treatment? And then what can we do for groups of people to try to help make their healthcare better? Provider roles are in managed care making sure that they have relationships with managed care organizations, which they do by getting their organization paneled and contracted, as well as making sure that the individual people who deliver that care are also credentialed. And so this is proving to the managed care plan that provider organizations have the right kinds of providers that the managed care plan needs to be in their network, that they have the right skills, the right training, the right experience, the right licenses, the right background checks. And provider organizations have to work with the managed care plans to make sure that that happens, as well as providers play a role in medical necessity review and authorization requests. So you saw the managed care organization wants to know, is this the right care? The provider is looking at the individual relationship that they have with a beneficiary and saying, we think that this is medically necessary. This is not something that someone's doing for cosmetic reasons, or it's not something that they're asking for that they don't need for any good medical cause. And then providers have to make sure that they get that care authorized, either by making a determination that it's medically necessary care, or in certain cases participating in a prior authorization process where they actually have to submit documentation to the managed care organization to support that request. And then beneficiaries have a role too. It's know your MCO and know any other insurance that you might have, because unlike the full managed care or the full Medicaid program, the regular traditional Medicaid program, managed care organizations do have particular provider networks. So you have to know whether or not the provider that you want to work with is matched with your managed care organization. And then additionally, it's communicating. MCOs may need information, particularly around prior authorization requests, or if you have a dispute, they may ask for additional documentation. Providers may need additional information, which may be parts of your medical history. It may be getting records from other providers that have provided you care in the past. And then quality surveys, which are really important to hold managed care organizations and providers accountable. The Medicaid program, the folks at DHCF, need quality surveys to come back so that they can figure out if improvements need to be made. MCOs and providers also do their own quality surveying, and they also need that feedback to make sure that they're delivering care effectively, successfully. So thinking about self-advocacy in managed care, there are a couple things to be aware of. One, there are different kinds of relief, and there are different stages in requesting relief if something happens that you're not satisfied. And then there are also different organizations that you may need to go through this process. So generally, if you're seeking relief, you're either asking for something to change in terms of a determination, like someone's telling you that you're not covered for a certain kind of care, or that they're not going to give you as much care as you want, or that you have some kind of payment responsibility. And those go through a rather formalized process, and then can be reconsidered and appealed if you're still not satisfied with a decision that's been reached. Separately, there are complaints. And so this is an opportunity to talk about being not satisfied, like with the quality of care that you received, or you were treated rudely when you called the office, or you just couldn't get a hold of anyone at the phone number that was provided. Those are things that can be complaints. They wouldn't necessarily be a dispute or change a determination of what care you're going to get. You're just asking for improvements. And then instead of reconsideration and appeals in that case, if there's a really serious problem, the Department of Healthcare Finance has a program integrity office, and they take formal reports about fraud or abuse if you think fraud or abuse are occurring. And there's also a process to manage appeals. I also highlight that this can happen in any setting. So you may have a disagreement with your provider about what kind of coverage or level of care you should be getting. You may have a disagreement with your managed care organization, or you may have a disagreement with what the district government is providing. And so in each of those stages, you may have, and usually do have, an opportunity to make a request for something to change, to receive a determination, and to ask for an appeal if that's denied and you're still not satisfied. There are some resources to help you navigate through this. And so I want to point out for you that each of the managed care organizations will have some kind of patient advocate or member services team or enrollee services team. And they should be your frontline contact to say, you know, I thought I was going to get this thing and something didn't work the way that I expected to. Can you help me to understand that? Is there a way that we can get things resolved? I pointed out in my takeaways up front that, you know, this isn't necessarily always going to go your way. These are still folks who work for the managed care organization. Their responsibility is to minimize conflict, but they have incentives to minimize conflict. It takes administrative time and energy to deal with conflicts. And sometimes if you don't get the help that you actually do need, then your care will deteriorate and for them become more expensive. So you can use these patient advocates and member services teams as resources. You just have to be aware of the double-sided nature of that transaction. They're working for you. They're also working for the managed care organization. You'll see the same thing in provider organizations sometimes. So I don't want to say that that doesn't also happen on the provider side, but you see it in a bit more straightforward manner most of the time with your managed care plan. Your next option is the MCO broker. So this is a third-party organization that will not tell you which managed care plan is best for you, but will help you switch. They will tell you what each of the MCOs is currently offering and how that matches your benefit eligibility. And if you've decided that you're no longer happy with your managed care plan, then they will help you find a new managed care plan. They can also sometimes, and I would say actually usually, they can also tell you things that you might lose because leaving your managed care plan does mean you're going to end up with a different MCO's network. And you might have some of those value-added services that each MCO decides on their own, and those services might not be available from a different MCO. So there might be things that you're not happy with the MCO that you have, and the broker can also help you understand things that you might lose if you leave that MCO. And then your third source of recourse is the Office of the Healthcare Ombudsman and Bill of Rights. So the District of Columbia does have a formal government body within the Department of Healthcare Finance, but actually not just addressing Medicaid, but addressing any health insurance services. And the ombudsman will intervene to help to adjudicate disputes between managed care plans and beneficiaries, between providers and beneficiaries. Sometimes just knowing the right people, helping to use relationships to resolve disputes, and also managing the formal grievance and appeals process if someone has an adverse coverage determination and wants a third-party review, which is your right if you've exhausted other options. Then there's government policy making, and we shouldn't stop, like I said, just with self-advocacy. We also want to make sure that people understand that systems advocacy is part of getting the things that people need. I reframe here again that all district Medicaid program services and rules are in partnership with the federal government. There are things that the district does or doesn't do because that's what the federal rules say they can or can't do. And so not everything is subject to change at the level of the district government. Sometimes you go to your federal lawmakers and rule makers too. But for our purposes this evening, talking about the district government, it is important to know that there's always a place for your voice with every branch of DC government around your healthcare. On the executive side, there's formal rulemaking that has opportunities for public comment before the Department of Healthcare Finance can put in place new policies and plans, at least the ones that require regulations. There are separate policies as well, which are usually influenced more informally. They don't have the same kind of level of authority within government, but they are the rules of the road. And so this is where talking to people within the department is important, because it's at the agency's discretion how those policies are written and how they're administered. And there are active processes to participate in that work. And so in particular, I point out the opportunity to advise the director of the Department of Healthcare Finance through the Medical Care Advisory Committee. Every state or every entity that's operating a state level Medicaid program has a Medicaid advisory committee. And in the District of Columbia, because we have both Medicaid services and other public insurance services that occurs through our Medical Care Advisory Committee, that includes representatives from provider organizations, representatives from beneficiaries, representatives from the government, and regular participation, if not formal membership, from managed care organizations and other advocates and stakeholders. It's a great place to get information. It's also a place where formally the public is able to provide advice to the director of the Department of Healthcare Finance. Legislatively, you also have opportunities to have your voice heard. The Department of Healthcare Finance goes through performance oversight and budget oversight with the DC Council. We're in that season right now. Performance oversight occurred a couple months ago. DHCF has their hearing on Monday for budget oversight for the FY23 budget. And then the DC Council also makes changes, not just through oversight, but also through law. They're the ones who write the DC code. And so sometimes things need to change in the DC code to make services better or different than they have been. At the beginning of the public health emergency due to COVID, the DC Council had to get involved because previously it wasn't possible under the DC code for the Department of Healthcare Finance to reimburse telephone delivered Medicaid services. And now with the change to the DC code, that's no longer prohibited. And the Department of Healthcare Finance then updated their rules to say telephone services are an eligible kind of telehealth services. And then finally, there's the judicial route. So the Office of Administrative Hearings sometimes does end up getting involved as one of those last resort options when everything else has failed and you're still not satisfied. It is a place where you can say, we're not satisfied not only with the determinations made by the managed care organization and the third-party reviewer, but we have a dispute that needs to be heard formally through an administrative law judge. And then eventually as well, the courts. This is a rare occurrence, and I think Melisa will tell you they try to keep it that way, but the district government does get sued occasionally, and that is your right under the statutory provisions of the federal law, as well as parts of the DC code if there's some reason that the Department of Healthcare Finance isn't implementing the code in a way that causes a dispute. So the takeaways again, this is the exact same, it's not a different slide, but just shared decision making. You have rights when you don't agree. There are people whose job is to help, but be aware of their roles and the conflicts of interest that might be involved in those roles. And then just be aware, do the self-advocacy work, but also to the extent that you have the opportunity, help the system change by engaging in the system level advocacy. So what are your questions? What would you like to learn more? And ways to follow up with me.
Great, thank you so much for that, Mark and Melisa. I know this is dense information. This is a lot to kind of take down all at once. But, you know, just per usual, like this is now public, this is live on YouTube. So please, you know, be conscious of that as you disclose particularly information about your children, and speak more in general broad terms. I want to open it up to the cohort and anyone that's back here that wants to ask any questions.
I do have a question. I know that right now, we're basically undergoing a shift or change to the managed care, and also I'm not really sure like about the changes of like the ages, like the transition age, like all of that type of stuff, right? So as a person that is not really educated in these processes, where can we go to learn more information? Because I try to like participate in things, but it's like almost like they're speaking a completely different language. And then there's like the thing of, oh, we want to include people that have, you know, lived experiences or people that are going to be affected by these systems. And then we get there and it's like, oh, like we have no idea how to contribute because the language that's being used is not accessible to us. So it's like, if I'm a person that, I'm gonna be honest with you, sometimes I feel like just the process triggers me, and then it's not worth it to me to try to advocate for myself because I'm not taken seriously or I'm not using the correct jargon, and then I find myself in a downward spiral. So it's like I might as well just keep my head down and keep it moving than to try to challenge anything. And I don't necessarily feel like it's good that I'm having that experience, but also like, how do we help ourselves? Like how do, because everyone's like, oh, you got to help yourself, you got to self-advocate, you got to do this, you got to do that. But it's like, I don't even know like where to begin really. Like we really need to have conversations about the fact that this system is not friendly to self-advocates.
Wow, thank you for that, and see people kind of co-sign in the chat for that. So go ahead, Melissa. I know you were about to get go for it.
Thanks. And Elizabeth, thank you so much for your comments. Well, first thing I would say, quite honestly, if you ever want to talk with me, I would be more than happy to spend some time with you and talk through the, you know, more details about Medicaid and do so in a way that hopefully doesn't get into kind of how we talk day in, day out with all of our acronyms and things like that. So I would be more than happy to sit down with you if that's something that would be, if that would be helpful to you. It can be in person, it can be phone, it can be a video chat, whatever. We have the healthcare ombudsman that Mark referenced earlier, Ms. Holt, that runs the ombudsman's office, and she sits in DHCF, and but she's got a lot of independence, and she knows. Maud just knows about everything, Medicaid and well beyond Medicaid, and I think she's just really a tremendous resource. And also knows how to connect you to different groups or information if you need it. And quite frankly, she'll probably do the connecting for you. She's just really fantastic. I know Carlito was just messaging me too, the managed care organizations. If you happen to be in an MCO or know folks who are, they do have folks that are there to be able to answer your questions and things like that. But again, I think what I heard from you is that my guess is when you're talking to someone, whether it's an MC or something, it's, you know, it's that challenge of connecting on the right kind of saying the same things, using the same words, knowing what they mean, things like that. So there's also a lot of other resources just generally that are out there about Medicaid that we can do a better job at highlighting on our website to get folks there. But I would also, if you had like your wish is made of what would it be to answer your questions, like what's the best format for you? Do you want a website where you can just peruse it on your own? or a place where you could have like an informal chat with some folks who know some more of the ins and outs of Medicaid and the different words and the different meanings. And when we say benefits, or you gotta, or just whatever, is there anything in particular that you think would be helpful to you, or that you would like to see that you don't see right now, or that's just too intimidating or triggering, like you mentioned, that just makes it like, I'm not even, I just can't.
Well, I just want to be clear, for me, it's not necessarily at the managed care level.
Okay.
It's more of an administration government level, because if we, like, for example, providing like testimonies, and like providing testimonies is somewhat easy because you're just telling them what your experience has been. But I'm talking about trying to get, laws change. And I'll give you a specific example. Depending on which managed care organization I have, my child may not be able to get ABA therapy at school, right? So I have that has been an issue for me. I'm trying to figure out like how that works. And they're like, oh, because of the billing, because Medicaid won't cover it if you have this or this and that. Like, that's a big contention for me, for like my son that has autism. And it's like, okay, realistically, you really expect a child to go to school for 6 hours and then come home and do 3 hours of ABA after school? No. So, and then it's like, those kind of nuances. And I want to be able to advocate to change the law so that it's not that way. But it's like, I don't know enough about it to even be able to explain that to someone in a more, and it's like, you guys may understand what I'm saying because you have a little bit more knowledge about it, but it's like me trying to convey the need and what the difference is, and why don't you just take them out of school and just have the doctor write a note? Do you like it doesn't work that way. I barely can get him into school, so I don't want to disrupt his school day, 3 days a week, 4 days a week, to pick him up early, because then guess what, he's not going to want to go to school. Why can't I just stay home with you and then go do my therapy? Understand the nuances of what it takes to support a child that needs these services.
Well, a couple things to that. I would love to touch base with you offline to talk more about what your MCO said about ABA in school, because I just would like to check in on that. So if that's possible, I would really appreciate it. And I just want to acknowledge Shioma's comment to your remarks. And I think you said it so well.
Yes, absolutely. And totally understand this. This is safe space. So this is why I think this space is important, to have access to Melissa and Mark and then the others of the HCF team that are here. And hopefully we can keep it going and create more opportunities like this. But Renee, I don't know if you want to vocalize your question, or do you want me to do it? But I think I'd love to hear you do it, if you don't mind.
No, I'm my kids are in the middle of an ABA session now. If you could read the question, I'm off mic and off camera because yes.
Got it. So Renee's question is mental health supports for Social Security and HSCSN. And so we just kind of went through what HSCSN is, Health Services for Children with Special Needs, beneficiary with a developmental disability already diagnosed. And having a hard time that, families do have hard times finding organizations that provide community-based supports, particularly for the older kids, the transition age, 17 to 24. And can I add on to that, just because I think for the benefit of those others in the cohort and those others that may be just listening to it when, on social media, can you break down like eligibility, like what is the difference between CACID and the other MCOs, and just give us the foundation for that, and then address Renee's question?
Sure, of course. First, there's Medicaid eligibility, and once you are you do the application work and you're determined eligible for Medicaid, you may have the option to enroll in the CASIP program. Okay, so your eligibility is already squared away, if you will. There's enrollment into CASIP because CASIP has, or HSDSN, however folks refer to it, has, focuses on kids with SSI or certain special needs. And so there's an enrollment process that if you meet, and I would have to get, I'm going to talk generalities and I can get the specifics, but you need to have SSI or SSI diagnosis. And we have just recently updated our enrollment process because it wasn't clear, and we do have it on our website now so that folks can see it and have a little bit more insight into how this works. And so then once you're deemed eligible, so that's the thing you go through with DHS or a service center or now through District Direct and online. And then if you're working with your doctor or you already have an SSI diagnosis for your child, you can get a referral from your doctor that says, like, I refer this child to CASIP. We do a review to make sure that the medical component's there. And then when that works out, or let's say, yes, you meet the requirements, and then we can enroll the child into the CASIP program. And, the CASIP program, along with the other managed care organizations or the DC Healthy Families program, however you refer to it, they provide the same services. They're required to provide the same services. In the HSCSN or CASIP, you definitely have access to case management, and we do expect case management to help. It should be helping out families and navigating the services and supports that you need. And then also, I would say that while providers, there can be providers in the CASIP program that may also participate with other managed care programs, that CASIP or HSCSN, they have, I would say, probably a deeper network of providers that are better able to serve kids with special needs. And then they also have, I think what I've heard from families in the past too, is that transition into adulthood. And then whether if you are transitioning into the world of the Department of Disability Services, should be helping with that transition as well. Shioma, did that kind of get to it? Okay.
Yeah, it sounds good. I would love to hear from others. Does it sound like, do you feel like you have a better understanding of that? And of course, like Melisa said, we can have offline conversations. I feel like that laid, but then there's the follow-up question of what the difficulty of potentially obtaining SSI eligibility for some children, and what is the waiver option, or what are other options if they are found ineligible for CASIP?
So a couple different things, and then I just looked at the screen, and I want to go back to Renee's question, try to get through the example on her question specifically. Okay, so an SSI determination comes through Social Security, which is not DHCF, but federal government. So earlier when I talked about Ms. Holt in the Ombudsman's office, if you're ever having trouble navigating that, Ms. Holt, she's got friends in SSA and the connections. That's one area that, well, it's not just one area. She is really, the Ombudsman's office can be real support there. We have within DHCF, the Division on Children's Health Services, that can provide some guidance, but ultimately the SSI diagnosis usually comes through Social Security, my apologies. And then you can also, through the enrollment process that we have, submit the information here, and then we work with what we call our quality improvement organization, Comagin, and they can also do a medical review to see if your child meets the designation. But I want to pause for a moment. Carlita has worked quite a bit on this issue over the past at least year, really longer, but very specifically on the enrollment piece. And so Carlita, can you speak to that a little bit more? Because I know you'll have the details better than I do.
Sure. So if you don't qualify for SSI, you can go through what we have for our CASA program. It's called our referral process. And that's where you get a referral normally from your provider. And the process, as Melisa explained, goes through our quality organization, Comagin, who will then review the information and determine if it's an SSI-like disability. And then that way the child can enroll in CASA, even if they don't get an SSI determination through SSA. So we've just updated that process. As Melisa noted, it's on the website. And so you can go out and get more information on that. And I'll also put my name and email address and phone number in the chat. So if you have any more questions, you can just kind of reach out to me directly, and I'll be able to try to help you as much as I can. And for the young lady Miss Davis, who also asked about getting access to services through at HSCSN, I just need to know if I don't want to have that conversation in front of everybody if you're not comfortable, but we can talk offline to see if, if you have a case manager and what services you're, maybe having a hard time getting, and we can see about working with your case manager to get you access to services and supports.
Great, thank you so much. Are there any other questions or comments, concerns? And there's certainly no dumb questions, but there are no questions that can't hopefully be broken down. So please feel free to ask.
I do have a question. Me, since I suffer with severe anxiety and PTSD, I was researching on the benefits of having a service animal. I was wondering if that's one of the things that can be, I don't know if that's a question that you all are able to answer, but also be supported as far as a service animal for people that have severe anxieties, because it's even hard for me to go into like a grocery store without or even like being in a situation with my children and I started having panic attacks. So even like supports like that, is that only for people with private insurance, but people that also have Medicaid, do we also have that benefit? And also we just came back to the city, and it's been hard finding services for my daughters. My oldest, she has ADHD, and I've been trying to also get her evaluated to see if she has another diagnosis as well. So it's been hard with trying to get her a psychologist, because it's everything you need a referral for it, and then getting her services, hopefully to help her to excel in life.
Thanks, Sandy, for those questions. And you stumped me a little bit on the service animal, but we're going to follow up. So one of the reasons I personally love working in Medicaid is I learn something new every day, and I will never know everything about Medicaid. So Sandy, we will follow up and see what coverage is for a service animal. I have not heard that request before, so I can't even pull on that kind of experience. So Nandy, we'll have to follow up on that one. My apologies for not having that off the top of my head. And then on accessing, finding a psychologist and whatnot, Carlita, do you have any suggestions on the issue regarding like the referral? I do know, and Mark may have may have additional information trying to try to find the right kind of a provider. I know, just generally speaking, in the district, doesn't matter if it's Medicaid or private insurance, there's seemingly never been enough psychologists and things. One thing I can say that we've done in Medicaid, which hopefully makes it a little bit easier, is that we do now allow psychologists to enroll in our program, which we previously didn't. You had to be a psychiatrist. But Carlita, do you have any thoughts on how we can potentially get Nandy and her kids connected where they need to go?
Sure. If Nandy can, again, I put my information in the comment section. If you can contact me and we can find out what health plan you're in, I can reach out to the health plan to see about how we can get you connected to your services. Or if you share your information, I can reach out to you. That's fine.
Great, thank you. I think we're just about at time, close to time, but I would love just one more question. I think is important as a foundation. Many of us here have children in varying ages. Some are adults, and of course, as was just noted, that some caregivers are also enrolled in Medicaid programs. So wondering if you can break down a little bit EPSDT, how that applies perhaps at different stages for pregnant mothers, for young children, for those at secondary transition, those who've aged out of, of the children and youth system. So, if you could just say that, I know that's a lot in like a minute or so, but can we try?
No problem. So EPSDT is for, in this case, children are defined up to 21. So
and EPSDT stands for
you're gonna do that. Early and periodic screening, testing, testing, diagnosis. EPSDT. Hopefully I got those right. And so for again, defined kids are defined under EPSDT as up to age 21. Again, I want to go back to one slide in the presentation. The comprehensive benefits of hospital, clinic, physician, vision, dental, that is across the board, regardless of your age, if you're eligible and enrolled in Medicaid. Kind of the extra, if you will, with EPSDT is that component that if it's determined medically necessary, so there should be access to that service for a child. And that's really the difference. And so there's nothing specific that more than your enrollment and eligibility into Medicaid to get EPSDT, if that makes sense. What we, the things that we expect of a managed care organization or even, just of an MCO is that, they're definitely sending out information and reaching out when it's time for your child to have a well child visit. Hopefully coordinating if they do see that you need a referral or there is a referral and following up and trying to make those connections as well. So Shioma, I don't know if I got that right on the mark, but I just do want to be clear that the overall basic, benefit package of those services is available if you are a Medicaid beneficiary, and then EPSDT just gives you a little bit more access for child to make sure that children have what they need.
Great. Thank you so much. I mean, that is a great foundation. And Mark, I don't know if there are any parting words, if you want to end on speaking a little bit about what the difference between accessing Medicaid in the community and accessing Medicaid in the schools. And that's a lot. I think Elizabeth raised that, like wanting ABA in the schools, but not being able to bring in a provider. Like, what is the way to go if you wanted that in the schools? We know that special education could provide that or other behavioral health supports, if not ABA, right? There are other behavioral health supports that children could be eligible for and youth could be eligible for in the schools. And we'll end on that. And I know I'm asking a lot of really comprehensive things and to sum up in a short amount of time.
Yeah, thanks, Shioma, and thanks for great questions from everyone. I've dropped in the chat a couple things just to make sure that people know where to find the healthcare ombudsman, because Melissa and I have both talked about Maud and her team and how great they are. And so put that link in the chat so you can reach out there. I also dropped the link to some DC behavioral health resources, since it seems like several of you are looking. There are a lot of organizations that are closed for new intakes right now or have really long wait lists that I won't say otherwise, but those are places that you can look. Yes, we believe in place-based care, and so we are trying to add more behavioral health resources and supports in every setting, from pediatricians' offices to child development centers to schools to wherever else it is in the community where people gather, and not to make people feel like they need to go to some segregated place to get those services. So that is a really important goal, especially for meeting the needs of young people with behavioral health conditions. But there's something to be said for that, even for adults. The integrated care settings are usually going to be able to meet their needs in more effective ways. And so it's an ongoing project. With schools, there are additional resources. There are also additional complexities, and so we do want to be mindful of the roles that school IEP teams play. We want to be mindful of the roles that clinicians, either DBH clinicians or CBO, community-based organization clinicians, play. And then your insurer may also, whether it's the CASET program, whether it's one of the managed care organizations, they may have other options. And so some of that really does depend, what diagnosis does your child have? What diagnosis do you suspect your child might have if you could get through the psych evaluation? And then which insurance plan is covering you right now? And that doesn't have an easy or one fit solution for everyone. But that's why we're trying to put these resources in different places and make it easier for those different professionals to talk to each other, to collaborate, and to deliver that care in an integrated manner.
Great, thank you for that. You guys have done an excellent job of putting big things in small packages. And I look forward to more conversations so that these things can be ingested in digestible bites here. But thank you for giving up your Friday evening, and everyone for giving up your Friday evening to learn about Medicaid, of all things. We hope that everyone keeps a safe, have a safe weekend, and we look forward for our next session. So next Friday, we're going to be joined by Rachel Sandlon and Dr. Olga Costa-Price of the George Washington University Center for Health and Healthcare in Schools, talking about the multi-tiered system of support. So we look very much forward to that. And thank you so much, Melissa and Mark and the DHCF team. Pleasure to meet you, Carlita, and look forward to being in touch. And again, thank your cohort. And we hang out just a little bit afterwards, so please feel free to stay on once we kind of stop going live. And thank you for anyone who's joined us on social media. Please feel free to reach out. If you're accessing the channel, you can always leave your information. We'll follow up with you if you want also more in-depth information, and we'll funnel that through DHCF and to the DC Behavioral Health Association as you request, or by the nature of your comments and concerns and questions. And everyone have a great evening and happy spring, everybody.